loud enough to
Innovations
allow.
Stakeholders Committee meeting. We're going to leave this door open so that it doesn't get too hot in this room. We've had to set it up, as you can tell, because it's not exactly made for this number. It will get hot in here, no matter what we do with the air conditioner. So we will, I'm going to check in. Katrina, can y'all hear us in Asheville? Michael, y'all can hear us? John, are you set and can hear us?
Yeah, Jesse, we're good.
You can because of the way it's playing with the. And Silva, are we good in Silva? I can tell that you are because of the movement. Okay. We'll start out by introductions here in Asheville. Lindy, we'll start over there with you.
Lindy Montana, IDD Care Coordination Manager, Buncombe County.
Lynn English, System Performance Specialist.
Janice Donovan, EOR. Eric, EOR.
Annette Kirkland, Summerlin Homes Provider Agency.
Price Story, Storybook Farm.
Suzette Woden, IDD Care Coordination Manager for Henderson, Transylvania, and Fulton.
I'm Jane Lindsay. I'm with the CFAC Committee and the guardian of an IDD individual.
Kathy Rader, I'm her parent. Wanda said she's coming, she's stuck in traffic.
Anya Fitz with Open Hearts Art Center.
Captain Reed with the Arts of North Carolina.
Carrie Nature.
Okay. Let's move to Boom. Michael, who all's there with you?
Scott Blaze with RHA. Roger Giles, Home Care Management Corporation. Darren Staley, Life Alliance.
Katrina Armstrong, IDD Care Coordinator.
I'm Tina Clark, the manager for the North for IDD.
Cindy Johnson, IDD Care Coordinator.
Joanne Prophet with Turning Point Services.
Christy Lupton with Watauga Opportunity.
Michael may take the play. Just up here, but.
Okay, thank you. Let's move on to Lenore. John, who's there with you?
Go ahead, Tommy.
Tommy Abel with Skill Creations.
I'm John Frazier with Smoky Mountain.
Catherine Shaver, Smoky Mountain.
And Mary Short and Katie Short.
Okay, thanks.
And we have nobody hiding in the
Julie
woods.
and Silva with you.
Emily Gaddis with Macon Ability.
Jody Miller, Family Support Network, or Region A.
Julie McClure, I'm a family partner with Smoky, and I serve the Western region.
I have with me.
We've already been on Georgia.
Okay.
Okay, go ahead.
My name is Mary. My name is Mary.
She's waiting for you to say hello.
Oh, hello, Mary. Thank you.
I'm Kathy Dills, Coordinator, Registry of Unmet Needs.
Okay. Thanks, everyone, for coming. The agenda tonight, we have performance measures. Lynn English is going to present information about our performance measures in NC Innovations. I'll provide some waiver updates. And we're going to talk some about the Registry of Unmet Needs and the changes that are coming with Smoky because of the creation of a new position, which Kathy just announced, in a way, Registry of Unmet Needs Coordinator. And then at the end of the meeting, we would like to discuss some of the vision and process of this committee and see if we can make some changes to make it more meaningful to members. So that it's not, I mean, there's only two reasons to have meetings: make decisions or share information. And sometimes a meeting can do both. And I've received some feedback from, just so that you can think about it, I've received feedback from some members about how they would like to do some closed session things after we talk versus just the membership, so that members the membership can give a formal recommendation to Smokey instead of just based on what we get in the notes and some of the discussion.
Don't be afraid of the front row.
Oh, okay, we'll sit on the front row. Hey, everybody.
You're half off the camera.
And so, your minutes are in your packet. The minutes from the last meeting, they're rather brief because they're rather brief because last meeting there was a presentation about care coordination. And when getting these out this morning, I realized that I haven't sent the performance measures by PDF to the group, but I will get that out before the end of the week. And anyone object to approving these minutes? Okay. All right. Good. So we can move on from the minutes. And we will move straight into the presentation about the Innovations performance measures. Lynn, you can, you get to move right here. Let's see.
Oh, she took my seat. Okay.
Just think you gotta get out.
All right, you have two documents in your packet. One is incident reports, an overview of incident reports, and the other is the Innovations performance measures. We're going to go over the incident category types just a little bit because in the Innovations performance measures, of which there are 28 that we report to the state, the first ones that we're going to talk about are the health and welfare measures, and those are taken directly from the Incident Reporting System, or IRIS, as it's owned by everyone. And we thought it might be helpful for you to have the reporting instrument that's used for those incidents, because the measures talk about level 2 and level 3 incidents. Those are the ones that are reported that we use to capture the measures. So if you look at the incident reports, you will see that there's a section on restrictive interventions, and it clarifies what is a level 2 and what is a level 3. You will see allegations, abuse, neglect, and exploitation, and again, it specifies what's level 2 and what's level 3. Basically, with all of the incidents that are reported, there's 1, there's 2, and there's 3. A level 1 is a lesser degree of severity of the incident. The level 2s are more intense when persons, there may be actions that need to be taken on behalf of individuals, and level 3s are those that are the most severe for persons. All providers are required to report incidents of level 2s and level 3s within 72 hours, with the exception of deaths, and I believe those are the time frame is a little sooner than 72 hours. I think it's within 24 hours for deaths that would be level 3. There are other descriptors on your handout for incidents, such as medication errors and what constitutes a medication error. Yes, Jane?
Under entry, the level 2 is treatment by a licensed healthcare professional. Does that have to be face-to-face, or can that be over the phone?
I have not read the manual recently, so I cannot clarify for that, but I believe it's face-to-face. But I'm not certain. I'm not 100% positive.
And I would say that it is face-to-face.
Because they have to treat.
Because you have to assess, and you can't really, yeah, I would say that it's face-to-face. With regard to the injury. You're talking about injury?
Injury, level 2 and level 3 injury.
Did someone have something to say? And move?
Repeat, Lindsay, or whoever's question.
Okay, it was asked under injury, under level 2, it says, any injury that requires treatment by a licensed health care professional beyond first aid, that's defined by OSHA. And the question was, does that have to be face-to-face? And our tentative answer is yes, it has to be face-to-face.
Okay, and so any fires that are level 2s or 3s must be reported. Suspension and expulsions, consumer acts that are level 2s or level 3s are explained, as well as sexual behavior, consumer absences, and suicidal behavior. And rather than getting into the explicit details of what these mean, let's move on to the health and safety measures, health and welfare measures on your handout, and
The
innovations performance measures. We report these measures. Some are quarterly. All of the health and welfare measures are reported to DMA quarterly. Some are reported on a semi-annual basis, and then some of them are reported, information's gathered and reported on an annual basis. So the first 8 are the health and welfare, and if you look at those, the first one is about what actions are taken to protect the individual when there has been an incident that has been identified as an injury or behavior, abuse, sexual acts, AWOL, illegal acts, and looking at the incidents to be sure that appropriate actions were taken and agencies notified. And again, these come from that system that the provider's reporting into. So our target is to get 100%, to know that all actions that have been indicated, all actions were taken. The second measure is about reporting incidents. The providers report incidents within required time frames, and that's 72 hours for level 2s and 3s, 24 hours for deaths. This particular item is one in which we are working towards 100%. Sometimes there's a time lag on behalf of providers. The incident reporting system is not always a friendly one to use in reporting, so we're working on this measure to increase the compliance within the time frame. The third measure is the percentage of incidents referred to DSS or DHSR in regards to the critical incidents. And again, we look at those from IRIS to make sure that those that need to be reported are reported.
I have a question on that one.
About deaths, where interventions might need to be completed and followed up on.
Lynn, this is John and Lenore. We've got a question.
Hi, John.
How are you?
Okay.
Lynn Short.
Yes, hi, this is Mary Short. I have a question on number 3, the percentage of incidents referred to the Division of Social Services or the Division of Health Services regulation. Wouldn't all allegations be covered under that? Wouldn't all allegation incident level 2 and 3 be reported to DSS or?
All allegations of abuse, neglect, and exploitation are reported to DSS or DHSR.
Okay, thanks. I just wanted that clarified.
Yeah.
Oh, wait, what, I'm sorry. Is that all verified, or does this include false allegations?
It includes any allegation.
Okay,
So we basically take it and turn it over to the DSS to investigate if it's allegations. Okay.
We have our own internal,
We do our internal investigation.
we have an internal critical incident review committee that reviews all of the level 3 incidents as well. So those would go before that committee, but there would be also a DSS referrals and DHSR referrals that should be made by the provider. If they haven't been, then we make them as well.
Well, and do these include the 12 hours that you don't provide paid supports for individuals living in their own home or in their family home?
I think this only includes those incidents that are listed on this incident overview of category types that are a part of the IRIS system.
Okay, that didn't answer if that includes the non-12 hours that a service provider is present. So a service provider isn't obligated to report incidents of allegations of abuse or injury during the 12 hours that they aren't the service provider.
If we become aware, yes.
Actually, yeah.
If we're aware of anything,
It's like a citizen, it's an expectation of citizenship that if you think that someone's being abused in any manner, that you should report it to the appropriate agencies.
Right.
And, I mean, it's just, yeah. Yeah, professionals have to, and if we were to suspect something was happening on the 12 hours where services aren't provided, it would be reported, and our providers would be expected to report it.
Okay, thanks.
For you.
Thanks.
Number 5 is the number and percentage of level 2 and 3 incidents where follow-up interventions were completed as required. And again, looking at the different level 2s or level 3s, and we strive for 100%. Number 6 is looking at making sure that individuals receive the medication as prescribed. And we look at medication errors for individuals that are reported in IRIS. And we are looking at 400% there as well. The number 7 is about medication errors resulting in medical treatment. So if there is an individual who does not receive their medication as prescribed, and the result is that they have to have an emergency medical treatment because of that medication error, then that would be a reporting item. And as a numerator, our strive for this, our target for this particular one is 0. We want no one to have had emergency medical treatment.
So on number 7, basically, any level 3 medication error would be reported in this one. Okay.
Should it not be just, to me, not just resulting in medical treatment or hospitalization, but how about pain and suffering of the individual that doesn't require hospitalization?
Self-reporting. I'm not going to report that I caused my kid pain and suffering. I'm sorry, I'm not. That's just, you're asking people to do what's probably not going to have the providers report it. Yes, Carrie?
Yeah, I guess that's what I want to go back to number 6 and just get an understanding. You're saying ours, this is the reporting system. Who reports this? Who's putting it in ours?
The provider.
The providers are the one who puts it in ours.
All providers.
Every person reports it, and the IRIS person processes it, and this 6 is 100% minus all those errors, and that gives you that answer. The question is what don't we know? Yeah.
And is the language interchangeable between consumer and waiver beneficiary?
Yes.
Is it? So you use both interchange, they don't mean anything different from each other?
They do not mean
They do not mean anything different. And I agree with you, Jane. I think there could be more there, but this is all that we're asked to report. So this is the definition that we have to use.
From the state.
Right.
From the state and from CMS, they approve these measures.
Can I have a suggestion now? Is, or maybe just a question and see if it does happen. Can a guardian look at their child's record if they're in a facility to see how many errors were made? They do have access to the record.
I would say yes.
And the other, she asked if a consumer or a guardian could access records about medication errors in facilities. And our response is yes.
There also should be some way for a parent or guardian to say that they want to be notified of any medication errors, any incidents, any injuries, any whatever. And they should be without having to go look through the
Without having
record
to
to
ask
find
for
it.
it. And typically that's what's expected to happen.
That is what's expected to happen. And in the IRIS system itself, when you look at, there's a whole list of names or who did you notify about this incident, and guardians and parents are listed as well. So, and the last measure for health and welfare is about restrictive interventions, asking if there are restrictive interventions that have resulted in medical treatment. And again, we would like to see 0 as the target for that, none reported.
So you're talking about restraints?
Restrictive interventions is more than just a restraint.
Isolation.
Any other questions about the health and welfare measures?
One more from me. Is this a live reporting system? Do you get it live? Is it immediate? Or is there lag in this when you get it back from North Carolina?
It's a question I cannot answer. I do not know. The incident team looks at those, and I think it's live, but I'm not positive if there's a lag or not. I really don't know.
The information's entered electronically within 72 hours, and we can access it. Yeah, we can access it immediately because providers are entering it into an electronic system for the most part.
Yeah. Even though it's, okay.
Is that on your website? So you can, no one knows what kind of.
It's very, yeah.
You're giving me 100% target here, but what are we getting now?
Yes, this is.
I guess it says on our website. This is the document I was supposed to email to everyone in PDF.
So we,
So where are we doing? All these measures are reported to DMA quarterly, so.
I have something to say about that.
Yeah, it is what we report.
So this is what you're asking for.
Right, this is what we're trying to meet.
This is the expectation of CMS, Centers for Medicare and Medicaid Services.
Lynn and Jesse, we've got a comment in Lenore.
Okay.
Yeah, hi, this is Mary Short again. These measures are reported at the Board of Directors meetings. There's a subcommittee, the Performance and Quality Improvement Subcommittee, and the documents are also on the Board of Directors section of the website, of Smokey's website. So you can, I do videotape those meetings and they're on my YouTube site, but you can look at the actual documents on Smokey's website and see the total number of incidents reported and what the performance measures are. Those are reported to the Board of Directors as well.
We have a question, and Boone as well.
it talks about, the results refer to DSS, Division of Health Service Regulations. Does that include the healthcare registry? Is that DHA or DHSR? Is that the healthcare registry for allegations of abuse and neglect?
Yes.
No.
No, that is not.
No, that's for,
And we're
that's
supposed
for
to
group
report
home
to the
health.
healthcare registry, are we not, if there's an allegation of abuse?
That's correct.
Yes, you are, but you would be reporting on that staff. This is us monitoring what's happening with the actual person receiving services.
If it involves a staff member, then that drops down. Did you notify the registry?
Right.
This is Roger. I got a follow-up question, number 3. The enumerator says number of critical incidents reported for waiver beneficiaries. And I'm a little confused because not all level 2 incidents are reported to DSS. So if you take that by the all innovations reports, you're never going to hit 100%, unless I'm reading that wrong.
Yeah, that's correct. That's a negative numerator denominator. They've had to look at some of the numerators and denominators and adjust them
That's
over
probably
the
another one,
past
right?
couple of years.
Thank you.
Thank you. The next set of measures are about providers. And there are 5 of them. And the first one, actually the first 2, are about newly licensed providers and providers who go through our credentialing process, making sure that they meet the requirements to furnish innovation services. So if someone who wants to begin to provide innovation services, they have to meet licensure and certification and other standards prior to that. And so our credentialing team would look at those who apply and make sure that they meet the requirements before they can begin to provide the services, and also look at their credentials ongoing. So that's where that numerator and denominator is coming from in number 1.
Are those open or closed meetings?
Closed. Number 2 is looking at the monitoring schedule to determine continuing compliance with the licensure and certification and waiver standards. And the numerator is those who've had a review completed and those that are scheduled for a review. The third measure, for those who have had a review, looking at the plans of corrections and making sure that those have been approved. So that's the numerator and denominator for those. Number 4 is looking at the number of providers who have had a plan of correction that have had a successful implementation of that plan of correction. And the last one for providers is making sure that all staff have completed all mandated training within the required time frame, and that is a part 2 of the monitoring that comes from Provider Relations Department. When they do the monitoring, they check for that. So that's our numerators and denominators for the provider measures. Any questions on those?
One that I would suggest that's very easy for providers is total number of providers and total number in any given time period that we're required to have a plan of correction. Because if that percentage goes up, you've got a problem in your system.
what you mean by part two of the monitoring? Is it something like?
Oh, 1 and 2, I meant measures 1 and 2.
So when you're monitoring, you get a report, you usually report back, and it's all included in that one report, right?
It should be.
So these are the only things that we measure with regard to providers
Correct.
Wow.
That we are reporting.
that we're reporting. We're required to report.
We're required to report, and these are all annual.
So are these CMS requirements?
Mm-hmm. They're all CMS requirements.
Because I would be interested in knowing how many providers have to do a plan of correction in a given time period.
And you can see those on our annual report.
Yeah, that stuff
That will be
Mary
listed
referenced
there.
on the webpage.
Okay. The next set of measures, and there are 10 of them, are the service plan measures.
And this is where we really get to looking at things very client specific, right?
Mm-hmm.
Okay.
Let's looking at the plans themselves.
On number 1, you got within 45 days of ISP approval, is that a CMS requirement?
That is in the waiver, that an individual who is a new participant should receive services within 45 days of the ISP approval. That measure is the only one in this section that's reported quarterly, so you'll find it on the quarterly measures. The second measure is, and a lot of these are measured by ISP signatures. So the second measure is the proportion of individual support plans that address identified health and safety risk factors.
Can she explain
The care
that?
management department has a check sheet that they use to look at all of these measures and all of the requirements and make sure that each of these elements are captured as they should be in the plan itself. There's a section in the individual support plan that addresses health and safety risk factors.
Got a question on one? Yes, we do.
What did you mean these are monitored by ISP signatures?
The data requirement for a lot of these measures and service plan is the ISP signature.
So if a plan is...
There's a signature on the ISP in the plan approval by the individual, the guardian.
So if the plan is signed, you say that the ISP does address the identified health and safety risk factors.
Yes, Mary, and for number 4, and for number 5, and for number 6, and 7, and 8, all the way down. That's the way it works, which is why this section takes a lot of paper, doesn't tell people much, because by the time the signatures come, people are tired. As a parent, I can tell you that that's often what happens.
But number 5, clearly, percentage of participants reporting that their ISP has the services that they need. I don't believe at least not since Home Supports, have I ever signed an ISP that contained the services that Katie needs. Because the waiver doesn't allow for the services that Katie needs. But you're counting that because I signed the plan? So that's where you would get 100%? No. Wow. Thanks for the clarification. Wow.
That is basically how it works.
Wow.
Yeah.
So basically, if somebody signs the plan, you're going to get 100% on all of these.
Because if you don't sign the plan, you don't get, if you don't sign the plan, you don't get services. Oh my God.
But a lot of them you will. Yeah.
What's that?
ISP is completed by the planning team meeting, or the care coordinator writes it. It's, the expectation is that it's reviewed with the treatment team and the legal guardian, and the legal guardian signs the plan.
But there's a section, Jesse, there's a section in the ISP that says, I disagree with. So is nobody reading that I disagree with section and you just come up with 100, oh my God.
That section is there, and you know, you would like, during our discussion about this presentation in the Innovations Committee, Mary, this same topic came up. We know that it doesn't, we should be paying more attention to that piece. We're not required to pay attention to that piece by the CMS or DMA. They aren't asking us to report anything with regard to the disagree with the ISP, or marking through those comments that you have to attest to before you sign the ISP. So we're very aware that there's a flaw there.
Not what they asked you to report.
Right.
Right, it's not what they've asked us to report.
Yeah, it's what we're reporting what we're told to report. And we've questioned it too. We question the manual for reporting. The only reason it even somewhat makes sense is because of some of the questions that we submitted, I would think. And we do hear your concerns about that.
On number 2, where a portion of the ISP that addresses the identified health and safety risk factors, why is there not also a section of how to resolve these issues? If it's truly a first and second plan.
This isn't about resolving issues, it's about supporting how we
Right.
on those issues.
Right.
That's the difference. Then you hope that in the issues they take back and develop a way to fix those problems. But all this is about is supporting it, it's not how you fix it.
Do we have information like this about how it is fixed? How all these outcomes are?
Well, there's a few that we're not meeting the expectation, right?
Which is not one of them. But, yeah, and the way that we currently report these, we would only need to have a strategy implemented if our aggregate, our totals fall below the 86%. However, each individual should be addressed through the care management review process when they review the plan. Ms. Carey.
If you read this question, where it says percentages of participants reporting that their individual support plan has the services that they need, that's misleading. If you're just taking that, saying, okay, they signed off, I'll accept these services.
That was my point.
You're saying their needs are being met, so it's misleading to CMS or whoever we're giving us reports back to.
That's it.
Say, hey, yes, we're getting all those services made. And that may be why when they're looking at this data in Raleigh, and then you have the legislators and everybody looking at that.
Because if that's 100%, why would you have any grievances or appeals?
Mechanism for setting the way, because Smokey did not create these measures. No, they came in this language.
But I think that signature thing is wrong.
And is there a way to get feedback to address those concerns other than, do we do that?
We're consistently giving feedback about those kind of things. And the work groups that are working on waiver development are just now starting to ease into the performance measure piece, because there's a lot of debate around it. And some of the performance measures are outlined in the actual waiver application, as in CMS has chosen.
Those are these.
This room is a pretty consistent concern.
Yes.
But CMS asks for this data, and they're the ones, and this is how we're reporting. Every element NC is signed off, and that's how they report it.
Yes.
Right. So you're essentially saying, though, that every numerator is the number of ISPs signed. These are misleading numerators.
Correct.
Yes.
Okay.
Yes. And we have
I just want to be clear.
who was trying to speak? Was it
Is it Sylvan? Okay.
Yeah, Julie.
I agree. This is Walter, Jesse. I agree with what she says. It's kind of misleading because look at number 5 there. If the team determines the service is needed, then by signing the plan, that means, yes, it's been met. But the reality is, if the services then are put into appeal, then that creates a whole other thing. And that's kind of misleading to the state because the state automatically thinks the needs are met. And I can't understand where Mary's coming from because just by signing that plan, that doesn't mean that that's going to happen. That's been the problem. It could be 6 months to a year or longer before those services get out of the field. So that can be a major issue.
It's kind of like you're given these forms and you've got to do them because you didn't create them. But it's kind of really icing over what the reality of the situation is. And you don't have to answer that, but it really is. You're given this form and it's kind of icing over what the reality of the individuals who are in the waiver and their parents and guardians are experiencing.
But it's a lot of work
Right.
on Smokey's side for.
Right.
I know, it's just information.
Useless work. Excuse me.
Yeah, there's
Yep.
no meaningful information there.
So does that opinion, can you pass that on, that this group says?
That's one of the things as a stakeholder group I think we need to.
Absolutely.
Is number 7 also
Yeah.
done by the signature of the plan?
Number 7,
No.
persons receiving services in the type, scope, amount, and frequency is actually, that information comes from the care coordination monitoring tools that are collected. That is an item on the monitoring tool. And so for every monitor that they do, those numbers are gathered and reported here.
So when they come and do chart reviews, or just others, they are taking data on how many, I know they look at the data sheets, but they are actually compiling information as to how many services are provided per whatever.
Claim reviews.
And claim reviews.
Just direct asking questions, are services being provided? We look at backup staffing and different reports. The whole, if you look at the monitoring tool, there's a provider section, a general section, and a legal guardian representative section, and all of those things are outlined kind of with dates, yes or no, in a concept section.
So is that monitoring tool entered electronically somewhere? Nobody's seen
Where is that monitoring tool? I've never
it.
seen it.
Oh, I've seen my care coordinator with it.
The care coordination monitoring tool.
Yeah.
Can we get a copy of that?
Yes.
Yes, it's on the DMA website. We can definitely send a link to it.
But are those entered electronically or is somebody actually hand calculating?
They're hand calculated.
They're hand calculated.
Every one of them.
The
And
information
that's
from.
the information we report to Stephen quarterly, and
Then we put it all together
so the care coordinator.
to get these numbers to
This
report.
monitoring tool is a quarterly tool that you upload for each individual person, and then they pull data, the care coordinators pull very specific data from that and enter it into a spreadsheet that is then taken and calculated and shared with the state.
So how do the providers know what's being sent in about them or their votes?
You can ask the care coordinator when they're doing the monitoring.
You can get a copy of the monitoring tool out after it's completed, correct?
Oh, okay.
Yeah, for the meetings, that care coordinator,
Yes. But if there's an issue, they should be able to address it.
Generally, if they see something.
yeah, they went to report it and,
They'll say, okay, you got so.
And the other managers can say differently if Suzette and I miss something to John and Tina are available.
Some care coordinators actually make a copy of that and leave it with us. Carrie Collins is really good about that. She wants us to see what she's reporting.
I mean, it's like, so it's not like it's your address lines for the individual.
We need to
Let's see, we got comments in Boone, and then we'll go to Scylla too, okay? So first is Boone.
I was just gonna say, it's appendix in the technical guide, so everybody has access to it. Shouldn't be a surprise.
Okay, Scylla?
Yeah, Jesse, it's Walter. Did I just hear you say that families have access to that when it's completed? And
I did not
get
say families have access to it. If I did, I misspoke. I mean, we can share it with families for sure. I don't think we automatically do though.
About the tool itself, not actually completed.
Yeah, the actual tool is on the DMA website. If you go to the NC Innovations page on the DMA website, there's a forums page, and the monitoring tool is on that forums page. But I bet you, that's in an Excel document, isn't it? So that you can't open it unless you have Excel.
Care coordinators typically have a hard copy on their person. It might be in their car, they might not be carrying it, but it's very easily accessible.
So families could request a complete copy in their charts, or does that cost extra funds?
Yeah, they just have to ask their care coordinator for it.
They can send you a copy electronically and through a secure email, or they can bring a copy the next time they see you.
And Jesse, I'll chime in, it's worse than an Excel spreadsheet. The one you get off the DMA website is a PDF. You can't enter anything electronically in it, it's a handwritten document.
PDF or PDF file. But you can look at it.
You can look at it and see what's there.
What's there.
Isn't it a fillable PDF?
Haha.
No?
That'd be too logical.
No, it's not.
Ours is
Okay.
Originally it was Word.
All right, so I think we've successfully established the fact that we don't like the way we measure some of these things.
I agree. I think we have.
All in favor?
But boy, she almost got away with skipping over it and people not understanding. So that kind of deception from staff pisses me off.
They're the only ones I know, so.
It's actually, James helped me, but I think this is the same one we used to look at 15 years ago. We get him to
They're just now actually paying attention to it. Help they can do it fast.
Wow.
The next set of measures, and there are 4 of them, are level of care measures. 2 of them, the first one is about the new enrollees to have a level of care completed prior to being receiving any services. And we look at the level of care and make sure that it is there and it is completed as required. So it's 2 different measures. Was the level of care completed? And then for a new participant, did it follow the processes? So are all the items completed as they are supposed to for level of care for new participants? For those who are continuing with the waiver, annually, there is a section on the ISP which a care coordinator will sign saying that this person still meets the ICF level of care, or there may be a recommendation that there be a new level of care completed for that individual. So that is what is used to capture those. Any questions about the level of care? They're pretty straightforward measures. And the last one is a fiscal accountability measure. And it basically is about making sure that we aren't paying any claims for innovation services that haven't been authorized. So we'll look at the authorizations report, the claims report that puts them all together and make sure that we're not paying for services that haven't been authorized.
Come on, somebody
That's all
ask.
28.
28. Any other comments, thoughts, and action about this topic? Any other thoughts in Ashland? Okay. Any thoughts about the performance measures in Boone? Michael, does anyone have anything to say in Boone?
No.
No. Okay. Boone's a quiet group. Okay, let's go to Lenore.
I do have a quick question about the fiscal accountability measure. Because wouldn't this be sort of where backup staffing issues would also arise, or underutilization? Wouldn't that information be able to be figured out? Yes?
It's a report that the backups, the team that looks at backup staffing could use to make sure, because it would capture those services that have been authorized, but there are no claims for them. So it could be used for that, but as it's used by myself in the Quality and Integrity Operations Department to report, I do not look at that.
Or like people who ask for, the 576 hours of respite, but they only use 300. Is that not being compared?
That is being compared on an individual basis, and on the fact of we're paying attention to utilization at both the systems level, the client level.
Okay.
And our utilization rate is hovering somewhere around 78%.
Wow.
It all depends on the service, really, and it depends on an individual, because there's some folks that are 100%, while there's others down around 50%, and some people that are less than that on occasion.
Oh.
And one thing that we've noticed from this fiscal accountability measure when compared to the backup staffing incident reports is that either there's a lot of service breaks occurring out there in the system, or providers are not reporting backup staffing incidents. Because out of our 105 providers, there are about 68 providers that we've not received a single backup staffing incident report from. So because of that, one of the things was going to propose to this committee is that we start asking providers to attest each month that they have had no backup staffing incidents when we don't receive a report.
Backup staffing incident.
A backup staffing incident is basically when staff is supposed to show up and staff does not show up.
Okay, so it's not that staff had planned to be off and you couldn't provide backup staff?
No.
It's simply that staff didn't show?
Staff's scheduled to be at work, they don't come, and someone doesn't come to take their place.
And not just with the no-show, they call in sick.
They come, yes.
That would.
If they call in sick and you can't get a backup, that's a backup staffing incident.
And how do those numbers compare versus, let's say, utilization in Nashville versus utilization in Robbinsville, Davisville, some streams outside Oxford? Are you looking at that? Because I imagine the utilization of those, the Silver Springs type areas.
We're starting to look at all of that.
Better to where we can.
But first all the providers need to report. We need to know about that before we can make true
I mean,
comparisons.
for backup, because you can look at money going out, is what people are authorized, and is.
You say to get back
Yeah.
to see if there are any
People are
trends.
billing pretty consistently.
Mhm.
You probably can look back 3 months and say, okay,
Noah.
somebody living in Bakersfield is only getting 20% versus somebody in Asheville is getting 90%.
Right.
And look at those numbers, because I imagine those rural areas, you know,
Well,
they change people.
And there's lots of variables tied to it also, because the more utilization tends to increase when relatives are providing services.
Well, see, that's what the thing about.
I was going to say, those 68 who haven't reported a single not backup staffing are using all families, right?
Provide services.
I'm glad I didn't learn something.
Staff that doesn't come. Okay, that guardian's gonna be forced to volunteer to provide services. So either they can say, well, I'm doing them, I'm gonna bill anyway, I didn't wanna do it, but I gotta do it. You know, either I can do it for free, or I can bill. Well, the majority of them are going to bill. So that's not accurate, whether it be any service at all that you provide, whether it be backup, personal care, skill building, any of them. Because if you've got a family member or a guardian, it takes, I'm sorry, somebody that's really stupid who's gonna work 10 hours and say, I don't want to pay. So they really don't have probably, 40 hours already and can't do another 10. Well, that's true in some cases, but, it's, I just don't get that piece of it, of really being forced to volunteer to do services.
And those incidences don't really apply in the EOR context, because if I haven't gotten backup staff and I haven't arranged schedules, then yes, I'm filling in, but I am not billing.
Mm-hmm. Yeah, because you can't as an employer of record.
Right, so
So
so you're not tracking incidents for that related to EOR, are you?
well, you, as an employer of record, if your staff did not show up, and you didn't have another staff to offer,
Even if they call in sick?
even if they call in sick.
But you're not getting in trouble for it, they just want to track
You're
the
just
trends.
tracking, we're looking for trends to see different pieces, and, but the challenge there's numerous challenges, because sometimes it isn't a backup staffing incident report, sometimes it is, it depends on the whole circumstance. And sometimes it's made up in the same week, there's so many variables that it's something very challenging to track.
Right.
But what do you gain from tracking? I mean, you spend a lot of time doing it. Either you allocate X and 27% was spent for some reason, or you didn't, but what are you gaining from all this time?
In those communities, it's hard enough to find one.
I think one of the things that it does is it distinguishes what is, between what is a family's choice not to have service versus what a provider cannot provide, or doesn't provide. So that's one of the distinctions.
Because sometimes a provider will have a staff member that they can offer that does not, that meets the basic requirements of the waiver, but the parent doesn't want to have a person work with them. Right.
In a way, I agree with what Don said in price, but if you've got a relative that can only do 40 hours a week, and staff doesn't come in, so the person that does 40 hours a week ends up being the backup staffing, and then they just get some other staff to fill in when they would do it, so they don't go over the 40 hours a week. So there's so many ways that you can play this game of, I got staffing, but you really didn't want to do it. Well, somebody's got to do it. You don't leave these individuals just sitting in a room and go out the door.
There's other ways to look at utilization. One, why are there holes? Is it just not people out there? I would want to know that. Gaps in service. Is it not enough providers, or there's enough providers that not enough people work? Are we getting better results with employee record? Getting higher utilization or less utilization? Those are things you want to know. And then where do you put the resources? Why is it that national high utilization, then the staff member can't. So what can you take out, provide that is doing well? That's what you get from these numbers that you do with the revenue. And that's the only way to improve it, because the thing is that, I want to know the whole stuff. I want to, is it goes here, but you have to have the money, and those coming in through this, so they know what they're authorizing versus what they're utilizing. Then at that point, then they can go back and try to figure out why.
But it's gotta be three-dimensional. How do you do that? I have staff, but they're not qualified to handle this high intense person, and I'd rather have nobody than somebody not qualified. So I'm adding, how do you add that third dimension to that?
And I'm looking at the big overall picture, because I think providers have to look at that. But when you're looking at it from utilization, and he's saying, you know, that high addition or low is, they're averaging, why is it? Because they have to look at the big before they get to the small. And is it everywhere, or is it just certain communities?
Well, that one report, I was at a board meeting and it was on staffing areas. I don't know how people can stay in business when you have hundreds of missed opportunities every month. I mean, would not attrition those people go out of business? We just seem to be spending a lot of time on this.
Yes, we do spend a lot of time on this. No doubt about it. But it is part of finding the gaps. And that's the whole system's purpose of it.
Did you not find the gaps from Madison County, that not how we came across the understanding of why our waiver participants out there in Madison County were not getting the services because you were able to see that they weren't being used? So the data does make a difference, and then you try to look at, you know, what provider we're going to get here in this county that's actually going to travel across or the community's looking at that as a whole too, to do the job fair thing out there to get providers.
Because if we're consistently getting reports where it indicates that the staff's not qualified to provide the services, then that informs the system too. Why aren't the staff qualified? Is it because of rates? Is it because of the training expectations? Because that tells us too.
But the providers are giving you that information.
Some providers are, but that's the next step. We need every provider completing their backup staffing incident reports, because that's an expectation in the waiver. And you're expected to report failure to provide backup staffing within 72 hours, according to the actual waiver document. And there is an electronic module now in Alpha MCS, our information system, that allows the provider to go in and enter this information. And that information, now that we're getting it electronically, we know that we're just receiving reports from a small percentage of our providers. And we have, in the past, communicated to all of our providers, sent out a list basically saying we've received instant reports from these providers, so they're doing what they're supposed to do. And then we received a lot of feedback that, well, we didn't have any because it was all service breaks. So one thing that we're proposing, and I'd like to put to this group.
What's the difference between service break? Wait a minute, you're losing service break and not providing.
Well, the service break is the client, the actual client said they didn't want the service.
Around January.
Or they're going on vacation, or.
Around January, February, we got reviewed about backup staffing, and it was because there were so many consumers that around Christmas took like a week off of their services. So it wasn't that we didn't have the staff available to provide the service, because if anything, we're overstaffed, because we have at least 5 administrative staff that are all qualified all the time. But here was like 5 different people who went home for Christmas or to their family's house or whatever. So those hours that they were allocated weren't used. So that sent up a flag to Smokey, and Smokey contacted us, and we sent them a little form, and we showed them our attendance record, and where they have been on the back of their documentation sheet. We actually write every day that they're absent, why they're not there that day. So it's documented, so we can't be like months away and be like, oh, why weren't they here? Oh, it's because Sue went to her mom's house, whatever.
Well, and part of what we could do with families is educate them that if they are not getting, if the staff didn't show up, making sure the care coordinators and informed of that so that they can make sure the providers following up with you.
That's the provider. Yeah, that is part of it, because sometimes the family doesn't communicate with the provider. And so that's, a lot of it's just the growing pains of the system. And one thing we were thinking about starting in July is sending a letter to any provider we do not receive an incident report from, basically sending an email with notification after this is active, with a reminder.
Add a session letter each month would be, it could be submitted electronically.
It's going to be something really easy, going to the email address that's identified for the provider. Is this accurate that you do not have any backup staffing and stuff reports? So that we can start differentiating whether or not we have good information.
And what you send it to EORs too?
Yes, initially that would be part of it.
I mean, because we need to get the good information too.
Mm-hmm.
Yeah.
Yes.
From being on the Client Rights Committee for the last 100 years,
That's a problem.
we reviewed the level 1 incident reports, and who sent them and who didn't, and we would have 300 providers in the system, and we would get 75 level 1 quarterly reports. So unless you're going to send a specific email to somebody, don't expect providers to just say, oh yeah, I didn't have any, and to remember to report that every month.
Well, so that's what we were going to, what we're planning. So basically, you're telling us that we should pursue what we're planning, whereas each month our incident report team gathers this data. If we do not have a report from Storybook Farms, we're going to send an email to you saying, is this accurate?
Yeah, if you can simply do a yes or no, and, then go back and do it.
That's our plan, is to make it super easy with just a response. Oh, we missed one, we fixed it, or no, this is accurate.
And then if you get no reports over a period of time, say for 6 months, then you can start.
She can be very appropriate.
To see if
It's especially effective at the General Assembly.
Dominating this too much in Asheville, we need to go to Boone. Are there any thoughts about backup staffing in Boone?
This is Tina. I in general have a thought. There was a statement made a few minutes ago that if someone doesn't show up to work, the families need to let the care coordinators know. But the families really need to immediately let the providers know, because if the provider queues don't know, they can't send a backup person out. And then it does become a report. And if the worker and the provider, if the worker and the family have a relationship to where the worker's not reporting, not works to the QP, and the family doesn't report it, then they may not know for a week or two at all, and care coordination can't do anything about that. The providers can.
That's a good point, Tina, and it really should be contacting the provider QP first, for sure. Okay, anything else in Boone? Okay, let's move to Lenore.
We do.
Yes, hello, Mary Short again. Well, as far as the limit on 40 hours to families and this issue with being forced to volunteer, I think if you truly were to develop the relative as direct service employee process so that those relatives could automatically be approved as backup staff, at least the services would be paid and delivered. And it wouldn't just be money that was not billed. The service provider wouldn't go out of business because they didn't have staff show up or staff was sick or whatever. The family didn't have, it just doesn't make sense not to declare the family member as backup staff over 40 hours. Thanks.
Anything else in Lenore?
That would be you, Tommy. I think we're good, Jesse.
All right, Silva?
there's only 2 of you here.
Yes, this is Walter. Or is Smokey looking at how much time is actually being spent by these provider agencies to track these incident reports and to look at reporting all this information? Because the last person I talked to in regards to, they were spending an awful lot of time as a QP just tracking the incident reports and reporting them to Smokey. And they were concerned that that was the majority of their time, and they couldn't serve the families or hire or whatever because they were too busy reporting to Smokey about all the incidents. Especially around the holiday season and stuff.
Okay. So the administrative burden attached to incident reporting.
I know you've had enough from Asheville, but I've got one thing I want to add, and all the training that providers are mandated to do for staffing. Why can't providers also be required in a training to train the families and the guardians of what is required in reporting incidents? Because the majority of family members and guardians do not even know how to report an incident, when to report an incident, or what is an incident. So if providers taught, or somebody, if it was required training, so that people would know what they're doing.
So you're talking about providers that if my son is at home with me and falls and scrapes his knee, then I have to report that to.
Yep.
And
Well, what if she's saying that if, like in all the years that not all the years, I think my son had services through a provider for about 5 years. I have no idea if there was ever an incident report filed on him related to anything. I had no idea of when to call a provider and say there was some kind of incident. I mean, it wasn't until I became an EOR that I even knew there was an incident report.
Wow.
Education for families on when if a provider completes an incident report, they would educate the family either in advance or in the past.
These events qualify as incidents.
I think it's part of the annual plan and on the initial plan. The care coordinator is every year on the first one saying, these are when if your staff is there, they fall straight, then you need to report it to the provider. The worker doesn't show up in schedule, and that becomes the care coordinator responsibility. The care coordinator sits there, so you know it should happen versus the provider that may cover the not there. Or if it's on a part of that annual plan that says, these are the things you're required to do as a parent of somebody seeking services.
Or make it part of the plan.
Let them understand, I mean, we did with Cascade that says, these are your responsibilities.
Right.
And the family signs it, and it's done by the case manager, same thing.
Well, we have the participant responsibilities form in Innovations. And perhaps it's more education around that and clarity around it. And I don't know that it really goes into a lot of depth about what the guardian's responsibility is, what any of the participant responsibilities. So perhaps it's just focusing on that a little bit more when it's time to sign a plan.
You know, they're going through, but they just say, hey, sign it.
Yeah, and that's, because let's face it, there's only one way to fix a problem, and that's create a form.
Or longer, as misleading as possible. I think we all have a responsibility to be as educated as possible if we are participating in this system, because we are all voluntarily participating in the system. We all should be as educated as we possibly can. Care coordinators do, we look for incident reports, we talk to providers when we know of an incident to say, please make sure you submitted an incident report. And there's some discrepancy in the system. We have providers that tell care coordination that we're not allowed to have incident reports. But that's not accurate. So there's a lot of, across the board, everybody's still learning what's what what's okay, what's not okay, and we all just need to be as educated as possible, and there is a lot of education that still needs to occur, with families and guardians, and there's also a lot of turnover in the provider world, so, you know, there are learning curves for QPs, there's learning curves for new staff on what is an incident report and what's not, and care coordinators are not in direct contact with people every single day. So if something occurs with a staff person, again, that's a provider agency, employer-employee issue.
And that's why the parent or guardian needs to be educated in when to call.
Yes.
Things are meeting quarterly then, right?
They're meeting quarterly or monthly.
What I'm saying is, as part of that, it's just those reminders.
Yeah.
I mean, I have to do it, well, it's not have to do it, in this case, managers and FC. They're constantly reminding families about what's required. That's our job, and that's why I'm saying, care coordinators should know their responsibility that says, hey, don't forget you have an incident, don't forget if your work doesn't show. They're not gonna remember, and I think if you're seeing people quarterly, you're seeing people, it's not in the form, it's not this, but you gotta get services every 45 days or every 90 days.
And I think that happens.
That has to, and the more that happens, the more it's sinking in.
I think it is happening, but I think it's sinking in, but it's we're thick-skinned. It's a slow sink. But I mean, and it doesn't hurt to do it more, but it's certainly, you know, we certainly talk about backup staffing reports and incident reports. And maybe John and Tina can also, or Suzette, I'm not gonna be the only person that speaks, but.
But Jesse, let me just say this, if anyone has and with our group, I mean, our phone's ringing all the time, and it's not just people calling in and complaining, I mean, it's just to add or to tell somebody, I mean, we know our families, we know their first names, we know all their children. I mean, if you have any problem with one of our staff members, if there's an incident that happens, if they fall or whatever, they don't call and tell us about it. We make sure everybody knows. So the provider agencies, they have a telephone number. Call them. You know, I mean, they want to talk to you. They want to know what's going on, or if you're not happy with your staff member, or whatever. If there was an incident or whatever happened. But if I had someone that fell or hurt themselves and came home with a staff member, I'd call the provider agency. And hey, they're open. We're 24/7, 365 days a year. They need to call and they need to talk to whoever's in charge and say, what happened? You know, there's no excuse for that.
But keys have to be identified too. Right. Just like I had an incident that I didn't have staffing, but I was told an incident report didn't need to go in because I provided the services. I'm not staff. I'm not paid to do anything.
Well, yeah, if you didn't get paid, you got to send an incident report. I mean, you know,
the agency really felt
if there was family, but you still have to tell Smoky Mountain, you know, why services weren't provided.
That agency is supposed to do the backup staffing report for sure. And I think one thing that it's very clear. Well, actually, is there anything clear in this? The picture's clear. But I'm hearing this is what we can do now, that asking a provider to attest that there's no incidents is reasonable as long as we make it easy. And that we need to do a lot better job of communicating expectations for both participants, provider queues, all roles. Defining roles is ever challenging in this evolving system, because as soon as we start to figure one waiver out, we move into another waiver. And so that's those things are being heard, and I mean, and really, we're accomplishing some of those things by doing this, because we're listening to one another. So I'm going to go one real quick time. I did go around with everyone about backup staffing, didn't I? One quick time, are there any other thoughts about backup staffing before we move on in the agenda? Boom. Michael, anything there?
What is my question? My name is Michael Nathan White again in Boone.
What is backup staffing? I have no idea what that is.
Michael, that, your department handles that, and they send out somebody to work with you if your normal worker can't be with you.
Is that what it is?
That's what
Thank
it is.
you.
You're welcome.
All right. Anything else in vote?
Nope.
All right, good, thanks, Michael. Well, let's go to Lenore.
I believe we're good, no more, Jesse.
Okay, Sylvan, any other
That was a
last
nice
thoughts
giggle.
about backup staffing? What's on to Sylvan?
I'm waiting for that. I was waiting for that.
We should disperse this group to locations so that on a rotating basis.
Water and Silva, she works for Smoky, and she's one of my favorite people.
I do need the right of way.
You're have folks assigned to go to certain locations, right?
So, let's say moving on through the agenda, some waiver updates. There continues to be development around the service definitions. The group has proposed a number of things to the statewide stakeholders. Mary regularly attends that group. She may have a lot more to share than I do about it. But the definition changes that there's going to be some significant definition changes to increase flexibility with regard to specialized consultative services. That service is being changed to where it should enable us to access more support for behavior issues and medical issues too, because it's going to allow QPs to do certain things under the supervision of licensed staff, and which will really increase the availability of positive behavior support plans and things like that.
Do you mean like licensed mental health practitioners?
Yes, licensed mental health practitioners.
And LCSWs?
Right. Yes, it's opened up to all licensed mental health practitioners as long as they have experience with IDD and they can do the supervision of certain parts. Yeah, it is. Now that I have one of those LCSW things, I'm focused on my retirement plan, and I was really advocating for that. But that was a piece of that definition. Respite is going to be available for alternative family living arrangements. It's just not clear exactly how that will be done. And we're getting ready to start discussing some of the self-direction definitions with the goal of increasing self-direction and the use of employer record. There's, Mary told me, well, Mary, why don't you share what you learned about relatives as providers at the last stakeholder meeting?
And the last stakeholder meeting was the last stakeholder meeting. Dave and Kathy Nichols, is that her name? Yeah. Announced that was the end of the state stakeholder meeting. They went over service definitions. They did not look at any other parts of the waiver document. They said it would be about 3 weeks, maybe a little longer. It would be posted for public comment. The entire waiver document, all 250 whatever pages. The group did not discuss relative as direct support employee, except for Dave Richard to suddenly announce that there was going to be a hard limit at 56 hours being the maximum. And so I, of course, called him on that, and I just pointed out it was arbitrary, just like the 40 hours was arbitrary. I got Secretary D'Elia to admit that to me years ago. So when I asked about the 56 hours and it being arbitrary, one of the people on the stakeholders committee said, oh, well, I think the thinking was it would be 8 hours, 8 hours, 7 days a week. So again, the stakeholder committee, the formal state stakeholder committee, did not get a chance to give formal input to DMA, DMH. It was just not gone over. Neither was the limit on sets of services. The committee was dissolved. So I'm hoping that there's enough clout with the people I know and the people they know that public comment is strong enough and is clearly, uses the word clearly that they object to whatever it is that they object to, be it a part of the service definition, be it the relative as direct support employee, be it the limit on sets of services, which is legally supposed to be a dollar limit, not an hourly limit. So hopefully everyone will object and use the terminology object so that DMA does clean it up and do what people want. I don't know what's going to happen with the clinical policy and if that is going to get propounded, but it was very clear that that group was disbanded. It was the second Monday in May, I think. So I've just been waiting for it to be posted at this point.
So we'll all keep our eyes out on the posting of the waiver for public comment? No, this would be the actual waiver.
The waiver law.
Document of law.
And if,
Yeah, it will be posted, and it will be posted for at least 30-day public comment.
yeah.
Can you send an email when it's posted?
I will, to this group. Okay.
And so Jesse, will service limits and rates and all of that be part of that document, or does that then come after the waiver document is approved? And with us being now about 3 months later than they wanted to be, because they had originally said in March, then does that mean we still can consider that we're on target for January 1?
We can still consider that we're on target for January 1 because once the document's submitted, CMS has 90 days to review. That review doesn't start until our public comment is up. So if it's posted July 1, August 1 would start our 90-day clock. And CMS could decide on the 90th day that they have questions. And as soon as they ask us, if they ask us questions, it restarts the clock for another 90 days for us to respond. They have started doing a little more, there's more effort to try to make things happen timely, especially since everything's electronic and out there for the whole world to see. So it's possible that we will have the new waiver by January 1 of 2016. The actual waiver document does not impact rates because the rates aren't embedded in the current waiver document. That's set for policy and administrative pieces. And actually rates and managed care can be set distinctly by each MCO. So.
But it does have definitions.
It does have the definitions for services, right.
And description of what families can do.
Right.
It's got those.
And it will have any of the limits that are identified in the waiver also.
And that's the document that matters, not clinical policy, not in the manual. That's the document.
Yeah.
There's also the waiver's going to end, so it's got to get one.
Right. And the waiver, the actual waiver document's law, but once the clinical policy is approved by physicians group, but it's also enforceable in appeal.
Is the comment period just going to be online? I mean, how's families supposed to be notified of this?
Well, we've been discussing that internally, and our goal is to notify families in more than electronic ways, whether it's a flyer that we expect care coordinators to develop.
So were you going to print out the waiver and give it to them to read?
So are you going to
I mean, that's definitely something this group
That
can
was more
suggest.
conversations, we're down the road.
With childcare.
But the individual comments are what matters, right?
Right.
So the problem with the forum is you can have 10 people agree with you, but unless those 10 people go online or call, can they call?
They can call.
But then it doesn't matter the collective. This is the time when you gotta get everybody you know in every nook and cranny to either call or go online.
So we need to abandon
She's talking to the lady from Madison County, there's some nooks and crannies in Madison County, let me tell you what. There are some nooks and crannies.
The night you print up all the pages.
You have to have someone to interpret that document. It's not like regular.
So the parts that, it will be, yeah, and a lot of the documents just form. Yeah, there's stuff that, I mean, it can be broken down when it's sent out to where, the parts that are relevant are highlighted. We can do that piece for sure.
Well, who's going to decide relevant?
It's just not
For you to ask that question.
Nice try, Jesse.
But the service definition fixes what families require.
No, limits on sets of services is what you need to pay attention to.
You wanna ask that?
Access and folks can comment on it.
Yeah.
So it's going to be a pretty, once that's posted, I wasn't aware that the posting was coming that quick.
Well, I think
We have a question in Lenore, Jesse.
it's important for everyone to be really aware of the limit on sets of services, because they're going to be discussing those individualized budgets. And again, it's supposed to be a dollar limit. So if they try to impose hours on that dollar limit in that appendix C-4, limit on sets of services, that is supposed to be dollar limits only assigned to sets of services. As I have said repeatedly, Kenny Howard at CMS, she cannot explain how our current waiver got approved with the hours in that appendix. It is dollar amounts. So the service definition shouldn't be the primary source for families to review. The budgets, because respite is going to be included in your budget amount, it's not going to be separate as it is now on the limits of sets of services. There's a great deal in this waiver that families and providers, hopefully our provider agencies, are going to know enough to look for their individual consumers to figure out if this waiver is going to continue to meet the needs. And there's a move.
Let me give an example. Mary, let me give an example of the sets of service, can I?
Yes.
Because I think that term doesn't mean anything for most of us. But if you have a family person who needs more than 12 hours a day of services, they're basically out of luck because the services are 12 hours a day max. So anybody who needs more than that can't get served at home. Is that what you're referring to?
Right. The only exception is that in-home intensive supports for more than 12 hours.
Days and has a fading plan.
Correct.
So we have, okay.
But
So translating it into terms that people live with might be helpful.
right. So the idea, if we're going to be assigned budget categories and budget amounts, if you choose to use all of your budget in personal care, and that buys you 16 hours a day worth of personal care, then that's what you should be able to buy with your budget. Now, as far as the skill building portion, maybe that's what the volunteer is going to do. Or maybe you want to spend all of your budget, if you're someone who is fairly high functioning, maybe you want to spend it all on supported employment. And you have someone who will volunteer all of your personal care. if the dollar amount is what you get to spend on the service definitions, then you will do what you need to do to get the services you need. The way the current limit on sets of services is written in hours, you don't get to make that choice that you want to use all supported employment or whatever it is you want to do. So once we're assigned budget categories and able to really use those budgets, I think families will get the services that they need.
Is that 2016?
Yeah, right.
That's supposed to be part of the 2016 waiver. But it's supposed to be a shift away from counting 15-minute units and assigning budgets based on need. But we'll see.
We need it.
Yeah, so, okay. So, that's waiver updates. Wow. Let's see, another update. As y'all know, we have a large number of people waiting for services, for innovation services on the Registry of Unmet Needs. And we've created a new position at Smokey, Registry of Unmet Needs Coordinator, and that's Kathy Fields. She's based in the civil office. So she's going to be working through the Registry of Unmet Needs and making contact with folks that are not receiving services. Wow. Contact with the folks that are receiving services to get a better grasp on exactly what we have out in the community. We already have people that are receiving supports intensity scales that are on the Registry of Unmet Needs because that informs the system, and it also, as long as they get a waiver slot within the next 3 years.
Is she someone that we would refer people to if they contact our program and don't have services, they need services, or have been waiting on the waiting list and feel like they're not being heard?
Yes. Kathy, what is your extension?
1155.
1155.
Kathy Deals?
Yes. And Kathy's got over 35 years of experience. She,
It's just hard to say, call Smokey, you know, they don't know.
if people want a name, when you say call someone, and when they call, if they call Access, they're likely going to get referred to Sarah Michelson, or, and Access in the future is going to be getting them to Kathy. Now, Kathy's not going to be able to talk with everyone instantly, and with regard to referrals for IT services, it's not typically considered an emergent circumstance, so there will be some delay in response time, but based on the frequency, it's going to be a full-time job for her. She's going to be also coordinating levels of care for people that are moving into the waiver with our waiver allocations and such. So, and we're going to start sending the notices out to people that are on the registry saying this is your date, so that you can hold on to that too.
Your date of?
Referral. Yeah, so that people have a document that they
Excellent.
that verifies that yes, this isn't a magic list, because what we've got is just we've not had the manpower to get the stuff out there, and the letters are already with our attorney for approval because they state you've been determined potentially eligible. This is your referral date, and then that referral date would follow the person throughout the state. So those pieces are happening with that, and we'll be updating information regarding that piece of the system as we move forward. The next thing on the agenda, are there any questions about the Registry of Unmet Needs in that new position?
You said Sarah Michaels, who's that?
Sarah Michelson, she's in the Access Department, and she often fields lots of the calls regarding IDs.
Does she have do you know her extension?
No, she's just in the call center. You can get referred to her.
a family can just call directly?
No, they would just want to call and say that they're inquiring about Registry of Unmet Needs.
Okay. And then the other question, shoot. We'll get on the next one.
Okay, any other questions in Asheville?
Are you gonna discuss the B3 meetings?
Not this meeting. We will be getting there though.
Okay.
Because we just had our last listening or last brainstorming session on May 28th, and we haven't got everything compiled, okay? You remember now, Carrie?
You said a letter of referral date will be sent, and then, I thought I heard you say something that it can be used throughout the state.
We would be notifying, we'll be notifying the person of the date that they were placed on our Registry of Unmet Needs.
Right.
And if they moved into another area that's not covered by Smoky, they would have that letter saying this is the date that I was placed on the Registry of Unmet Needs.
So it's gonna be effective.
And it would be, right now, we already do that with our other MCO partners. If someone shows up in, a good example, we had a person show up in Coastal Care, and they contacted us and said, was this person on your registry? Yes, they were. We gave them the referral date, so they honored that date.
Oh, wow.
And like we're doing that with a person right now that's out of Winston-Salem. So we communicate with one another. This is going to be more concrete for folks. Because
They don't know that.
Right.
They're afraid to move to another.
I know, and that's something we've got to fix with this system.
Excellent.
Because North Carolina is North Carolina, even though I certainly prefer certain parts of it. It's still North Carolina, where we are. Okay, so any questions about that in Boone?
Anything here?
Mm-mm.
Michael, I'm going to call on you. You might have anything to say?
Well, this is Michael Nathaniel White in Boone again. I honestly think we need to do some serious work on this.
I agree with you.
About.
Yeah, we all agree on that point. All right. Any other thoughts, Michael?
How about y'all? Y'all are
We are on your team, but we don't have any other thoughts.
all right.
You just summed it up wonderfully, is what it is. Okay, let's move to Lenore.
We're good here, Jesse, thank you.
Okay, how about Silva?
I just have a comment that I'm thrilled that we finally have this position, and that there'll be a good contact person and somebody to work with them. And from a former keeper of that list, I'm super excited.
Okay. So, the next thing I have on the agenda is, and this is based on feedback that I've received from several people. We've actually been doing this now for almost a year.
Mm-hmm.
Our first meeting was July 29th of 2014. And our numbers have fluctuated. The largest meeting we've had included 75 people. And the smallest meeting was probably hovering right around the number in this meeting. So, some of the feedback I've received is that it would be better if we formalize the actual committee piece more. We have 24 people assigned to the committee, and some of the feedback I've received is that it would be better at the end of the meeting, after hearing the information we had to share and some of the debates on topics, there was a closed session that just included the committee members, where a formal list of recommendations was provided to the Innovations Committee. So that's something I would like folks to consider between now and the next meeting. and you can send ideas about it. We can also discuss it. Are there any thoughts about that idea here in Asheville?
I think we're a committee that was formed to be open to the public, to listen, but we're also supposed to be a voting committee. We've never had a closed session where we voted on anything. We've gotten a lot of information from Smokey, which we needed. But I think we also need to have just sessions with stakeholders and to be able to listen to what their concerns and what their ideas are and how they'd like to see this waiver be implemented, move forward, go on with. And I know you can have 50 different decisions. So as a stakeholder committee, if we meet afterward to vote, but I think we need to be sending to Raleigh a letter of the detailed things that we as stakeholders see as needs and what needs to be met and ideas of how to meet them. But we sit and listen to what Raleigh wants. And then they say, what kind of input do you want? Well, sometimes I feel like we sit and have zero input into anything, and I think we really need to start sending letters, every committee, every stakeholder committee, and say, this is what we see needs to happen, this is what's going wrong.
Take the performance measures.
Right.
Be specific.
Right. To be, specific, have performance measures. We're listening, but we're not doing anything.
Okay. Any other thoughts, Asheville?
Make for a really long meeting.
I have a concern as a non-committee member that I started coming to these meetings in November. I've learned a lot. One of my concerns is that it seems to be a very stable group with some very missing individuals that would, I think from a committee standpoint, have a responsibility to represent different areas of services, and they're not here. So being not on the committee, that concerns me that we might not be covering the scope.
Okay.
What's an
I think
example?
that's a...
Have you got an example you can share?
I just know that there's a couple of people on here that, I mean, I have a vested interest in EOR because it is so successful for my son, my family. And there's people on here who are also EOR and they don't come to the meetings.
Okay.
Okay, so, and we all have very different situations and we all deserve the right to be represented.
Okay.
And that's what I think one of the committee's responsibilities would be, is to represent the scope.
Okay.
And the...
I think it would be interesting to see of the folks who are named to the committee, how many of them have been here? And, you know, how often?
But that's already, that's underway, and I think that we need to, everyone that was appointed for this first year, I think we need to just have a reapplication process, to be honest. With not necessarily an application, are you still interested? Here's the expectations.
Right.
Because if you're going to be on a committee, you need to show up. When it's 90% of life showing up, right?
Is it a year?
It's a year commitment.
Oh.
Is that from July or?
It was really from July is when we first started talking about it.
If there was if there was the open forum and then the committee piece, would people want to do that all in one night or break it up and have an open meeting and then a closed meeting and an open meeting and a closed?
Well, you said you could also look at doing an open forum every quarter and doing the actual closed meeting every month or 10 months a year.
But isn't that what we were created to do?
Well, what we were created to do, we're mandated to exist. I think.
Mandated to vote,
But it's not necessarily mandated what our role is.
So there's no policy policy and procedure as far as.
Well, we've got the charter about, we're to inform Smokey and the system as a whole. How we choose to do that can be broken down and reworked, because, we could kind of shape this more along CFAC now that we see that we've got a turnout and people that are willing to participate consistently. And we're ultimately supposed to be reporting partly to CFAC, but as we learn this whole thing, what can make it most effective? How can our voice be heard the most?
But Jesse, if you do, if we're open for where we can only come in quarterly, if we're not on the committee, then, and you do it Monday nights, I guess, because we're in the process of, sending your emails out to all of our family members and contacting them and letting them know about the meeting and trying to get them to attend some of them. So they'll know also what's going on without us telling them what we interpret.
Well, and the continuation of continuing to send emails and information will not change as that listserv grows. And it's actually going to improve because we do have a digital media staff now. Our website is getting better slowly. So those are things that we can definitely continue to work on.
I think if we close it, we really got to look at the provider meetings or some other way to consistently get out information, whether it's to families or providers or both. If the stakeholder committee becomes more of a closed format, then we still got to figure out a different way to.
I don't think it should become a closed format. I think that we should have an open format with all the input that we can get. But then if we're supposed to send something to Raleigh with a list of what we as stakeholders see that Raleigh doesn't see, they're sitting in Raleigh, they're not down here with us.
So really more of a vote, and this is our recommendation.
I think if you close it so we can really get into what is it, these performance measures that we're going to change. And as a committee, the committee's able to say, okay, this is how we think it should be worded. And the development, they come back in a month, okay, this is really what we want. So then that's able to present it in an open meeting. So, okay, this is this committee came up with around performance measures. Then I think you keep it closed so you can actually get that conversation and get it. So just being talk and stuff on paper about what it is that we think it should be written as. Then that can go to CFAC, then that can go to the board or whatever. And then there's a concrete document from Smoking that says stakeholder group that's going to go to DMA that says this is what we think. And then that holds.
At least we have a voice.
Yeah.
I agree with being able to vote on something and send it out. But the Provider Network Council has groups in every area. And then the meeting that they have once a month is an open meeting for any provider, whether you're on that council or not. And they still vote right then and there with everybody else there.
Exactly.
So we can do the open discussion.
They vote with the people who have been elected to the committee.
Exactly.
Okay. So we could move in that manner.
I like that.
Yeah, I like that idea too. Thoughts about this and boom. I like trying to catch Michael asleep.
I can speak. Did anyone else want to say anything?
Go ahead,
I'm Roger Giles, and I am a member. I have noticed there's only, from last time, there's only 7 voting members. I'm not sure if we've established what quorum is or anything like that. And I'm sensitive later on, which I'm happy with. I don't think we should have a closed meeting unless there's a special circumstance. I do like the notion I think someone just talked about as far as, like Jesse, you recognize an action item, someone make a motion, thank you, and someone second that for it to go forward. But I don't know I think we had a closed session. I think that might actually separate people than join people. Just my own personal thought.
Okay, well, any other thoughts in there?
This is Scott with RHA, and I also was concerned about how you're going to determine, a quorum would need to be established, I think.
Yes.
Of the committee. And also, maybe they would need to know that there's going to be particular votes that come up each meeting, and getting that attendance for those voting members is very important.
Mm-hmm.
And I think if we communicated that we would be taking action on things to make recommendations formally, that may help with attendance. Any other thoughts of them? All right. How
I'll
about,
make a comment.
Lenore?
Yes, hi, this is Mary Short again. I see absolutely no reason why you can't simply take attendance of the actual committee members, and then if there's an item someone wants to make a motion on and hold a vote, that the committee members vote. But to close these meetings, I just don't, I don't know where you would even have legal standing to do that. But I would be wholeheartedly opposed to it. CFAC isn't a closed meeting. Board of Directors is only closed when there are certain legal issues that they go into closed session for. But this committee certainly doesn't discuss anything that would come even remotely close to what a closed session would be needed for. There's no... No, the Board of Directors Executive Committee is not closed.
No, what?
They're all posted on Jerry's website.
No, what?
It doesn't sound like this group wants to do it. It sounds like they just want a formal way.
Right.
Way of making recommendations.
Right. Yeah, right. So if you have... Take attendance.
Or do you have something else, Mary?
No. No, just take attendance. It's just that simple. So you know who votes and who doesn't.
Okay.
No fair asking questions faster than I can push the mute button.
That's Walter Green. Okay.
Yeah, I think it should be open to the public. I think you'll get more of a rounded view of where there might be gaps, where there might be issues. Because if the family's upset, then they could come and actually talk and might see where there's some issue with the definition or where there might be an issue with gaps in services.
Okay.
That's it. Like the fact that you give us this feedback, because at least it gives us something to look at.
Well, and so I will take that back to the Innovations Committee because I'm hearing the group say that we want to formalize voting but keep the meetings open.
Yes.
Yes.
And
sorry, I can't vote.
Actually, what's that?
And we can vote on that.
And we also need to start with the next fiscal year, we need to start enforcing attendance. It's like when a person commits to being a member, if they're not coming, they report that they're not coming, and after so many times, they either designate their vote to someone. Would that be a possibility?
I think you need to set a minimum standard for attendance. And, I mean, if somebody has missed 3 times in a row, I look at the amount of information that you distribute in 2 hours. I mean, sometimes it's hard to sit through it, but I sure have learned a lot. And if you've got a committee member who's not here 3 meetings in a row, they're missing a lot.
1 month ago, that flat out going on. So I got 1 to 2 months prior, he wouldn't want me in the strip. So be careful with that. And that's another state points, but last time we wanted me was in the strip because I was sick dramatic ways. So when we started doing that.
Well, but so there's exceptions. So there's exceptions. I mean, you always have, you want to set a standard.
You set a standard and then you put it to the committee.
And then you have exceptions that can be.
So that's.
I'm not talking about the.
You don't want to push people into it.
We're just formalizing the purpose of the committee and the roles of the members, and if you would send a substitute if you're ill, who you report to, what's your expectation?
Or if you're voting, maybe you can vote. We could definitely explore those things. The next item, our next meeting is actually scheduled for June 29th.
Yep.
6 to 8. Everyone's okay continuing with that meeting, or is that too close?
Mm-mm. Can I have one question, one final question. Jesse?
Jesse, we've got one final question here, please.
We had an agenda item to discuss the Cardinal Innovations settlement, and that has not occurred at this group yet. Can that be on the next meeting for sure, please?
It was on last and we didn't get to it.
Correct.
And it was, I will do what I can about that. I can't guarantee that it will be the next meeting because I know I will not be here. But it would probably be best if I could get Tracy to discuss that.
Yes.
I'm thinking. And
Yes.
Because that's who really should be discussing it.
Tracy Hayes, the general counsel?
Yes. Yes. So that's on my action items to reach out to her about that.
Good, thanks.
Also, something the next, at the next meeting about the issues between NC Fast and NC Tracks and people losing their Medicaid, and it started when NC Fast opened their new system, or they started it actually back in the summer, but they started enrolling CAP clients, Innovations clients, in September or October, and that's when it started.
Yeah.
And we have clients who have not been eligible for Medicaid. Sometimes DSS and the Smoky staff have manipulated things.
We could, and that's the challenge, it's like we could discuss that in that meeting, or in this committee, but the only thing that we can do is provide information about it, because it is an issue that has caused lots of grief for lots of people, and it's continually being worked out. We are at a point now where when we go to DMA saying we need override, we're starting to get the overrides at least. So we have made some progress with it. So that's why I'm not sure it's a good place to bring it here because it's such a technical thing. Because we're dealing with them on each case-by-case basis.
Well, and when I talked to DMA this morning, they said, "Oh, really?"
You just talked to them. I believe that some people's
I've been in a meeting with providers statewide. And DMA's like, I'm tired of hearing that was a problem.
Okay. So I will do my best to get Tracy here for June 29th.
Okay.
I can't guarantee that.
True.
But we will try to address that piece. That will be the June meeting. Someone from Smoky will be chairing it. And it will probably be me. Because I'm going on vacation. Yeah. Again, yeah. But we appreciate everyone coming out and the commitment you have for persons with intellectual disabilities and trying to improve the system, even though sometimes it doesn't feel like we do enough. Anyways, thanks, and we'll see y'all in July. Remember, the next meeting is June 29th.
Good night, Jess. Thank you.
No, you're right. Not July. August.
You didn't see it in August.